The government doesn't have an incentive to allow the patient the decision-making authority because the government goes, well, Father knows best. I know what's best for you. So I'm going to do what I think is best for you, which it turns out is best for me because I have all these bureaucrats whose jobs are dependent on me and are going to vote for me.
Hello, welcome again to another episode in the Let People Prosper show. My name is Dr. Vance Ginn. I hope you're having a prosperous day. Well, today I'm delighted to bring on a former guest and someone who I've known for quite a while now who does a lot of great work on healthcare and really providing a path forward to empower patients relative to bureaucrats and politicians and the corrupt system and overly governmental system that we have today. And it's none other than Dr. Dean Waldman. Dr. Dean, welcome back to the Let People Prosper show.
I'm very happy to be here.
Well, it's a pleasure to have you on. And since you were on last time, we've been working a lot on this new project, the Empower Patients Initiative, which is going to a report published by Americans for Tax Reform on their website. And then also a new book titled Empower Patients, 2 Doctors Cure for Health Care. This one's more for a general audience. The other one, the report's kind of taking a deeper dive, but it's a great overview of what's going on in healthcare. And I'm just excited about talking about this today. But before we get going too far, Dr. Dean, let me go ahead and read your bio for the audience, and then we'll jump right into it. So Dr. Dean Waldman is a professor emeritus of pediatrics, pathology, and decision science, former director of the Center for Healthcare Policy at the Texas Public Policy Foundation, where we worked together there for a number of years, and former director of New Mexico Health Insurance Exchange. And now we get to add this, co-author with me, Dr. Ginn, of the book Empower Patients, 2 Doctors Cure for Healthcare. You can follow him at x.com at Dr. Deane W, which is DRDEANEW, and other information that I'll put on the show notes page. So, with all that stuff going on, and people can find out more about your background. We talked about that in our first episode, which I'll put in the show notes link. But let me ask you this first. You know, you've seen healthcare from almost every angle, it seems like, from medical school, from looking at the MBA side, from working at University of Chicago and doing a whole bunch of things. What personal experiences led you to conclude that the real cure for healthcare starts with empowering patients rather than reforming government programs? That's a big ask there. But I think that will help set the stage for why do you want to do this? Why are we doing this? and what do you hope to accomplish?
You asked me a good question. Let me give you the honest answer, which is frankly quite personal.
Yeah.
Namely, I come from a doctor family. Literally everybody in my family has been a physician for the last 4 generations, at least, that we know of. So our family dinners got to be rather like sitcoms,
Yeah.
So you might call them sick sitcoms. But anyway, the point is that I grew up in an environment where the patient was bluntly the only thing that mattered, and the patient was in charge. And when I was a little boy, I would hear my grandfather or my uncles, my father and so forth, argue about how to get that done, namely how to get the best care to the patients. But it never was part of the discussion that there was a third party in that decision process. Okay, so then I do all the things that, my bio says. I go to the best schools, and I train at great places, and I get into being what I really enjoyed doing, which is pediatric cardiology. I just love kids, and they seem to like me, and they feel comfortable with me, and so everything. And I had a great family life, and so I'm out there practicing medicine where I belong, doing what I enjoy doing with the people I like doing it with, namely little kids. And I'm unhappy. I'm miserable. And I look around and everybody else feels the same way. And I'm going, why? I mean, we're doing all this great stuff for patients, and yet we're all unhappy. We're all frustrated. All the nurses and doctors are complaining all the time. And I began to say, well, why? I mean, what the hell is wrong with me, maybe?
Yeah.
Okay. So I went to business school at the age, believe it or not, of 55. And I figured, okay, I was the chief of cardiology at the University of Chicago. And I said to myself, well, it's me. I don't know how to do this right. So I need these business, like your financial knowledge, because that will help me make this system focus on the patients and get the patients the care they need when they need it. Okay, so I go to business school and then I start working and I find out that no, I may have the title of chief of cardiology, but I don't have the power to change how the system works. It turns out that third parties, neither I nor the patient has that power. And that's what got me to where we are today, because I began to say, okay, well, the right persons to have power, decision-making authority, are A, the patients, and B, the doctors advising the patients. And why the hell is anybody in that equation? And the answer is they shouldn't be.
Yeah.
And that's drove me to where we are.
Yeah. No, it's fantastic. And I think, I've learned a lot from you over the years that we've been working on this, because, for the audience, we started this process probably almost a decade ago. I think it was about a decade ago.
Close. Yeah.
Working on different healthcare reforms. And of course, you've been doing this for a lot longer. You've got 11, 12 books now on something related to this. So it's kind of a building in process. And I wonder, Dr. Deane, as we've worked on this for a number of years and you've worked on it many more, I don't know, what stood out to you about things that we can actually get done? Because you look at Congress, you look at the states, and what we've seen is massive amount of spending. As we note in our book and report, is that it's about $5 trillion, $4.8 trillion of spending across the United States on healthcare. And then we've talked about how that exceeds the amount of federal taxes that are collected in total of about $3 trillion. And then you look at some of the other, almost that amount, about $5 trillion or so dollars. And then you look at the amount of what we call burden, the cost, the waste, and the bureaucracy and everything else that's underneath that being about half of that total cost. So maybe around $2 trillion. That's not even going to care. And it's just so frustrating to see all these third parties, whether it's the government, which we call kind of the main problem, but also private insurance companies through employer-sponsored health insurance and everything else. But I wonder, even through all of the stress and frustration, why do you envision that there will be a better healthcare system in America?
Because bluntly, one of my favorite TV series was it's not on anymore. It was The Newsroom. I don't know if you saw it. And in one of the things, they describe what they call the greater fool, which is somebody who is told and, quote, knows that X is impossible and gets it done anyway. Okay?
Yeah.
He or she just has enough drive and faith in themselves, as well as faith in their solution to whatever the problem is, that they say, you can call it impossible, but we're going to do it anyway. And frankly, that is my crazy attitude, which is patients have to be in charge of themselves. I mean, that's called, forgive the phrase, liberty or freedom, whichever word you happen to like.
Yeah.
And now we're going to discuss for a second one of your favorite topics, which is incentives.
Yeah.
All right. The problem, if you look at our system, is that the incentives of the people who have the authority, namely the control of money, their incentives are not the welfare of the patient. The only person who really has the incentive to do the best thing for the patient is the patient.
Yeah.
Hello?
Yeah.
So shouldn't the patient be in control of the money?
Yes.
Okay. And so the government says, well, we're doing this in your best interest. But the fact is, as you just said about a minute ago, half of all healthcare spending in this country goes to some form of the regulatory system. You saw, we have this graph in the book, which I call it the graph, because it says in sort of one graph the reason why healthcare doesn't work in this country. It is a graph that shows the growth of the supply of physicians versus the supply of healthcare bureaucrats over 50 years, from 1970 to 2020. So that's, Obamacare and HIPAA and all these other regulations. Actually, the implementation of Medicare and Medicaid, which were 1965. So all of that goes into that. And if you look at that graph over that 50-year period, 5 decades, the supply of physicians has increased 100%, namely it's doubled. And the supply of healthcare bureaucrats and their salaries has increased 4,400%. Okay?
Yeah. Crazy.
44 times increase in the number of non-clinical healthcare workers as opposed to those who actually provide care. So you wonder where the money's going. Well, there's your answer. Where the money's going, that's $2.4 trillion worth of care that the American people didn't get.
Huh. Yeah.
And so I start salivating going, well, what if the people had control of that money and spent it on themselves?
Yep. Exactly. Great points there, Dr. Deane, as always. I think too, as you were just illustrating, is that there's so much money that's not going to the exchanges that take place. Because, as we talked about and looked at as in markets, people come together to exchange based on the determined prices of their subjective values for whatever that good or service is. In this case, it's healthcare services. And so ideally, you would have it to where when you go to the doctor as a patient, to your point, you should be able to talk to your doctor and, ideally even negotiate if you want, or there's a set price schedule that you could look at and then go online and look somewhere else to see what someone else is charging, and then have a marketplace to evaluate the ability and the skill set and the productivity of those doctors, along with the need and desires and the income ability, the willingness and ability to buy that service from the consumer, which we just have, they're separated in healthcare because we don't have, as we talk about in these reports and books, and you've been talking about, is that we don't have a free market in healthcare. No matter how you want to look at it, it's really not even a market, Dr. Deane. It's socialism encapsulated with some market activity that happens within, but based on government direction, not on profit and loss or marginal cost and marginal benefits of the individual, to allow for the best services at the highest quality at the time that we need it. That's affordable and portable, all that fun stuff. I think would happen best through a free market. But it seems like, Dr. Deane, over time, whether it be, Medicare, Medicaid, as you mentioned before, the employer-sponsored health insurance, which is this tax break that businesses get to give us health insurance that started after around World War II, and the price and wage controls is a fringe benefit for us to get that, and it just stuck around forever. But the issues here maybe go deeper, possibly, Dr. Deane, about healthcare being a right? Like if we are destined to have healthcare as a right, and we all want people to get care, but the question is, who decides? And if it is a right, then maybe there is a need for government to be involved with. But I don't think that's where you come down on this. Well, what do you say about that idea of healthcare being a right?
That actually is obviously a touchstone and an emotional, frankly, explosive device.
Yeah.
When people want, healthcare is a right. Well, if you think a little bit about healthcare as what it is, and then think about what a right is, you realize that in a free society, healthcare cannot be a right. Healthcare is the service, essentially, the services of a nurse or a doctor or a therapist. It is their work product. It is their activity. It is their, forgive the phrase, freedom.
Yeah.
Okay. It is their choice to work in this field. All right. Now, if it's a right, that means that the person who has that right has the ability to say to the doctor, this is what I want, and you have to do it when I want, where I want, and you don't pay for the right to have free speech or assembly or freedom of religion. You don't pay for a right.
Yeah.
I mean, look at the Bill of Rights. You don't pay for any of them.
Yeah.
Okay? Well, that means if healthcare is a right, then you don't have to pay the doctor or the nurse. Well, this is crazy. Okay? Healthcare is not a right. Healthcare is not a privilege. Healthcare is the personal service, just like a lawyer's service or a dry cleaner or an accountant. They provide services to the people who hire them. Well, doctors and nurses are service providers, and that's what should be exchanged for the clients or the customer or the patient's money.
Amen. We the patients, right? That's what Dr. Deane and I have been saying.
I use that phrase all the time, as you know, because I like to remind people, who we are. We the people, a free society based on individual liberty, and we are also we the patients because we all, sooner or later, need health care.
Yep.
There are no exceptions. I don't care what your skin color is or your political affiliation or your religious persuasion. You're going to need, or you need now, health care, period. We the patients.
Yep.
And so we the patients should be in charge of we the patients.
Amen. Yeah, that's right. That's right. And we outline this clearly and in details and a number of references. If you look at the ATR report, and we made these for different audiences. We have this report that is Empower Patients Initiative, which is really the deep dive. So all of you nerds who are watching this, who really want to dig in the weeds and the policy walks like me and Dr. Deane, you want to read that, but also read the book, because I think what the book does is not only look at this from from us being policy walk, Dr. Deane and I, but trying to humanize it in a way that people can understand. Because just like Dr. Deane just mentioned, he's not an economist, right? But he's looking at this from an economic perspective in some sense. And we also look at it from system thinking, which we talk a lot about in the book, right? Because you're weighing trade-offs. Someone's not going to give up their services without something in return. Why should a doctor or a nurse go to work and help you be better off if they're not going to be compensated for their service?
But
it can't be right.
Here's a key. What you said is true, but someone would say, well, doctors and nurses are paid by the government, and so they're getting paid. So why not have it? And I turn around and say, yes, they're getting paid, but they're getting paid not a market price, not the price that the consumer thinks they're getting paid. I'll give you an example in a second. They're getting paid what is left over after the insurance companies make their profit and after the government pays itself for that massive amount of bureaucracy. And so until the person who actually takes the service is the person who decides what the right price is for that service, until you have that, you will not have aligned incentives, to use your economic phrase. Aligned incentives. Aligned incentives meaning that the most money goes to the most value for the person who's paying. Okay. So people don't really understand what's going on, but I'll give you an example, because we're talking about price and money here. I mean, I did procedures on babies with heart problems. They're very delicate, blah, blah, blah. Put catheters in a moving heart and, inject contrast and devices and balloons and all these things in order to help a child who has a malformed heart, and I'm trying to get the blood to go the right way rather than the wrong way. Okay. My charges for these range from as little as maybe $1,500 to as much as $10,000 if I had to put in a device, a pacemaker or a stent or something of that nature. Okay? That was my charge. You know, but I'd love to have the audience guess for a second how much Medicaid paid me, because they paid the maximum allowable reimbursement according to the government schedule for that code that gets put into the bill. The answer is, everybody hang on for a second, $387.
Wow.
So that's what I got paid, my charge. So if you had price transparency, which is a big deal right now, well, you'd see, Waldman got paid $2,000 or $4,000 for this procedure. That, he saved my baby. That's kind of reasonable. But in fact, I got paid $387.
Yep. So clearly not the right quote unquote price.
That's not the price that the parents would put on my saving their child's life.
Right.
Okay.
Yep. And it's to that point that we don't have a truly well-functioning market price, because there's not really that much of a market in healthcare. If we break that down from the demand side, there's a lot of subsidies, right? And you mentioned earlier about the cost of government spending on these programs, but also we can't forget the cost of the forced taking of the taxes to make those payments. So it's also redistributing funds in the private sector as well, going to something that's not ultimately going to be best for patients in the longer run, or maybe even in the short run sometimes.
If you think about it for a second, we touched on this earlier. One of the things we're saying is essentially get government out of healthcare. Well, if you think about that for a second, that means, in theory, if you could do that, $2.4 trillion wouldn't be spent. Well, that's literally a balanced budget.
Yep.
If you got healthcare into the hands of we the patients and took government spending on itself out of healthcare, you left the money in that's going to care right now, but you took you withdrew the $2.4 trillion. Well, you're the economist. You know that literally would balance the budget.
Yeah, no, that's exactly right. That's what we're running right now, $2 trillion a year in deficits. So that's exactly right. And it's also frustrating, right? Is when you look at the demand side, we saw the excess, subsidies and the prices that aren't really set by the individuals within that marketplace by a third party. And this leads to more demand than we otherwise would have. But even on the supply side in healthcare, we talk about this, there's a lot of restrictions on how many hospitals can be opened or who can provide services, whether it's nurse practitioners or doctors. So there's licensing that's involved. And there are other factors. The FDA, when you get into healthcare on drug prices, the amount of time that it takes to get drugs to market, there are all these supply and demand limitations or restrictions imposed on the market, which is why not only is it over the spending is dominated by government, but even the marketplace itself is being restricted from government, meaning that it's not a free market at all. It's much more like a socialist healthcare system, which is why I think, or don't think, but know that we overspend and we overtax because of how much we're spending on healthcare, which brings me kind of to my next point, and you can say anything you want about that as well. But you've also said for a long time that health insurance is not the same as health care. And this is a central theme in our book. Can you explain what why this distinction matters so much and why policymakers continue to get it wrong?
Regretfully, I have to say, I think they don't get it wrong in the sense of their agenda.
Yeah.
They get it right because they control healthcare through their regulation of health insurance. Okay?
Yeah.
Now, what matters is the patient, again, not the bureaucrats. So why do I keep saying coverage doesn't equal care? Is very simple. And I'll give you the examples on both sides, and then why it actually is bad to have more government coverage. Number one, people without insurance, uninsured, still get care. They walk into an ER, admittedly, more expensive because the ER is a hell of a lot more costly than a pediatrician's office or a general or a family practice office, but they don't have a doctor, so they don't have any money, which our plan would provide them with money, but we'll do that another time or
we'll
read the book.
Yeah.
So people without insurance get care. Worse, people with insurance don't get care. I can give you a chapter and verse. Certainly, there's plenty of examples in both our paper and the book. Bottom line is people get a promissory note. That's health insurance policy says you'll get care. It doesn't say what care. It doesn't say when. And so there are people in Medicaid, and this has been documented, and again, I can give you the references of people dying, waiting in line for care. If they had gotten the care before it was too late, they would be alive, but they're not. This is what we call death by queue, waiting in line for care. My point is that coverage, that is a healthcare policy, doesn't assure you, the patient, doesn't assure the patient is going to get care, and certainly not in time for when the patient needs that care. Now, the patients assume that that is true, namely that, well, I have Medicaid, so I'll get care, and I'll get care when I'm sick. No, that's not the case. So that's why I keep saying that coverage doesn't equal care, which gets me to the last point on this issue, which is the seesaw effect. Now, we discussed this in the book as well as the paper, and it's really important for people to accept what I'm going to say, which is counterintuitive. Namely, as more people have government insurance, access to care goes down. Now, that's horrible if you think about it for a second, because when Medicare and Medicaid, when Medicaid was started, 4% of the United States population was eligible. They were disabled. They were survivors by definition. They were impoverished children. Those three groups were what Medicaid was intended for. In 2023, 24% of the entire United States population was on Medicaid.
Yeah.
Okay? That's a heck of a lot of healthy people, able-bodied people, etc. So as that number went up, as the number of people with Medicaid insurance went up, wait times to get care went up, which is exactly the opposite of what the people expected. Because, well, wait a minute, I have insurance, so of course I can see a doctor. Well, over a third of physicians in the United States don't take Medicaid patients anymore, and that number keeps growing, largely because of the regulatory burden. And number two, because, I mean, this is crazy. Yeah. I don't know what else to say. I can't tell you how many patients I have to fight. I used to fight every day. And by the way, I would say most physicians fight every day with an insurance company to try and get the patient what they need, because the insurance company will say, oh, well, we have a contract with Dr. X, so you have to go to Dr. X. But I know that Dr. X doesn't have as good surgical results as Dr. Y, and I want to send my patient where he or she has the best chance of survival, so I want him to go to the guy with the best results. Nope, sorry, can't do that.
Mm-hmm.
I mean, this whole system is, as you would say over and over, has malaligned incentives.
Yeah.
The insurance companies don't have an incentive to do the best thing at the right time for the patient. They have an incentive to make money.
Yeah.
The government doesn't have an incentive to allow the patient the decision-making authority, because the government goes, well, Father knows best. I know what's best for you, so I'm going to do what I think is best for you, which it turns out is best for me.
Yep.
Because I have all these bureaucrats whose jobs are dependent on me and are going to vote for me.
Yep. Politicians are rent seekers, right? They've got to win re-election somehow.
That's exactly right.
And it sounds good. We're providing you with health insurance. We're giving you Medicaid. We're giving you Medicare. All these things sound good. But, Thomas Sowell, one of my favorite economists, always said that in the policy world, there are no solutions, only trade-offs. And that really puts that point directly on. You hit the nail on the head, Dr. Deane, with that point, that these are trade-offs that are associated with that. And I think, we've went on now for a while about the problems. And there are a lot of problems in healthcare. And I think what we are addressing, that we just addressed, are problems that have been discussed, but not to the level that we are, to be honest. To be frank, with what I'm reading, with what other people are showing, is that they are just reaching the surface. Like right now, in the quote unquote one big beautiful bill, there's a good discussion about who should be covered under Medicaid. And there's this discussion about work requirements, to where those who are work capable, also known as able-bodied folks, if you can work, you should be working to get the Medicaid. But even with those smaller changes compared with our bigger ones that we're about to get into, those would still save, trillions of dollars over a decade if you can get those savings in place. And one thing that's kind of concerning to me, Dr. Deane, is that they're wanting to push it off until December of 2026, any sort of Medicaid or work requirements, because that's after what? The election. That'll be after the midterm election, so they don't have to worry about any sort of regulatory changes until after that's over. And they should be doing it now instead of later. And my bigger point here, though, is I think we're still missing the forest from the trees, is that you still have government dominating the system, even if they can make some of these reforms, which I think are meaningful. I do think that some of those things need to happen. But I think it should be in a broader discussion. Maybe it's too soon. Maybe they don't want to get into that. But I think that's what we're hoping to push forward, Dr. Deane, with our approach with Empower Patients, is that we need to look deeper. We need to look broader, and we need better solutions, quote unquote solutions, to reduce the trade-offs, to use Thomas Sowell's points. Okay. And I think that's what we've really done here with the Empower Patients initiative. So we have all this money that's going into the system. And what we would like to do is to start with education program of getting people to understand a lot of the problems, but also figuring out what are some of the solutions. Maybe part of the dialogue of tapping in Congress and across the states, I think is helping our process though on the education. But where do you think? Where would you like to get started with really getting into our initiative?
I'll answer that, but first I want to say something that you touched on, but I want to make it really clear. We look at healthcare like a sick patient, okay? Or a sick system, whichever way you want to look at it. It's the same thing in this situation. You don't treat the symptoms until you first identify the root cause of why the patient is sick. And then you try and treat the root cause. And when you do that, the symptoms will go away. And so my point is, you said earlier, yes, the changes in Medicaid are a good step. And people will say, well, we can't have a shock to the system. We need to do things really incrementally and gradually. And, it's politically dangerous with the midterms coming up to do this stuff that Waldman and Ginn want to do. And, no, we can't do that. Well, as a physician, you and I both, as physicians for the system, we say, well, wait a minute. We've got to be clear with the people who should know the answer and have the authority, namely we the patients, what the root cause is, and then gradually deal with that root cause. The root cause is the whole third-party system that gets in the way of patients deciding their own care and spending their own money. That is the root cause, and we need to address it. So, for example, you asked me what a first step is. A first step is really simple and, quite frankly, will be readily acceptable to we the people as well as we the patients. It should be acceptable to Congress, but I don't think that they will do that, namely what you and I call the transfer, which is right now 157 million Americans get their insurance through their employer. They get their insurance through what is known as employer-supported health benefit, okay? So the employer chooses an insurance plan, and the employee basically has to take whatever the employer says. The problem is that this is, as you said earlier, and let's get it out there, this is a holdover from World War II, literally passed in 1943, wage and price freezes.
Yeah.
Now, the fact is, all the other wage and price freezes were repealed at the end of the Second World War. That's 80 years ago. The one that wasn't repealed was this one. And so we say, well, wait a minute. That's an average of 23,000, in 2023, that was an average of $23,968 that the employer took of employee money and gave to an insurance company.
Right.
We say, okay, well, and by the way, the employer has a tax advantage when it does that. Okay. We say, okay, let's repeal the wage freeze and say that $23,000 goes to the employee and it's tax advantaged if they put it in an HSA.
Yeah.
And let them go shop for their insurance, shop for their care. Well, that creates a market of 157 million Americans. Half of the U.S. population will suddenly be in a free market.
Yep. It's huge. And what's interesting about that, and you're exactly right on that, Dr. Dean, and I'm hopeful that we can keep pushing in that direction. You know what? There has been more discussion about this as well. I mean, you've got folks like Brian Blaze and Michael Cannon and some others that have been talking about this recently on this employer-sponsored, supported health insurance tax break, basically for businesses to provide us that health insurance. And so incentives matter. And so when you give that sort of a tax break, of course, businesses are going to want to do that more. And so there should be this shift over to the consumer. And like you said, what we would like to see are what's called no limit HSAs. You know, health savings accounts have been around for a long time. People use them. I use them now. And you have some flexibility, but it's not as flexible as what we would like for it to be. We would like to be no limits to what you can use it for.
For example, right now, if government passed what we call the transfer, and that 23,000, well, it's 24,000, went to the employee, no HSA in the United States will allow you to put that amount of money. And we say, why should there be a limit to your contribution?
Right.
Okay. You want to put $24,000 in there because we just transferred the money to you and it's a tax advantage if you do that?
Yeah.
Okay. Then let's do that. Well, what if somebody is better off and has a chronic illness and wants to put more money, put another 10,000, we'll say, into the HSA. So you have 30 or 40 or 50,000 in the HSA. Why not? It's your money.
Yeah. You could do that right now with your 401k. I mean, you won't. That's right. You're right. You can put how much ever you want in there, and I think this also is a good point, though, Dr. Dean, where that money, that $24,000 that the employer is paying to your health insurance, that company, that money would be going to me, the worker. They would be receiving that $24,000. Because I think some would say, well, yeah, but that's extra money. No, it's coming out of your pocket. It's just being redirected.
It's you earned it.
Right.
This is your money. You earned it. It was a wage freeze effect, if you will.
Yeah.
I'm sorry, but we don't need it. As a matter of fact, it is distorting, to use your word, the market enormously. It is giving your money to somebody whose primary goal is not your welfare.
Mm-hmm.
Their primary goal, quite bluntly, is profit.
Yeah. Yeah. And
how do they make profit? Here's another thing that people don't seem to understand. How does an insurance company make profit? The longer they hold your money, that is, the less they spend, the more they have for profit.
Mm-hmm. Mm-hmm.
So what we call the 3D strategy, delay, defer, and deny. I mean, the whole pre-authorization process has one goal, which is to defer and delay payment for your care. But the trouble is, you need the care now.
Yeah. Yeah.
Okay?
Yeah, exactly.
And by the way, if you get the care now, your doctor ain't going to get paid for anywhere from 9 months to 2 years after he or she provides the service. Well, wait a minute. How many businesses can survive that if their accounts receivable are 2 years or 4 years out there? The answer is they can't.
Mm-hmm. Mm-hmm. Yeah, no, that's a great point. And then you have more money in the private sector. There's more activity going on, so we get higher wages. There's a lot of benefits on the economic side of this as well. I think another big part of our approach, the Empower Patients initiative, is to come up with block grants to the states, basically trying to decentralize more of the control out of DC to the states and ultimately to the people, of course. But if we're going to have some programs like we talked about earlier, are there market failures or are there government failures, or maybe there's a combination of both? But given that we do have Medicare and Medicaid today, Medicare is a much higher cost than Medicaid. But regardless, what happened is Medicaid was enacted by Congress, but basically gives a lot of the operational authority to the states. And the states are the ones who will fund part of it. And the federal government still funds the majority of the Medicaid dollars. But there's a combination of those things going in. And the states are incentivized to put more people on Medicaid or to expand Medicaid because they get more federal funds. So they keep trying to draw down these federal funds, which brings up the price and the costs and everything else even further. And so what we've suggested, and others have done this too, but I think a big part of this is federal block grants to the states. Take how much ever you want for Medicaid, block grant it, and give it to the states in this FMAP situation and other perverse incentives that are within our current structure, and allow for those states to have more flexibility to determine what their own healthcare, quote unquote, system is going to be. If Texas wants a more free market path, which I hope that they would, and have HSAs for all the Medicaid people and everything else, which is something we model and look at in Texas in particular, because we have a lot of data and we both live in Texas and everything, but we could be saving billions of dollars a year. And not only that, but the federal government could be saving billions of dollars a year as well, because they don't have this uncertainty and rising cost of the FMAP situation and other factors that go into it, and just said, here's a block grant, increase it by inflation or something very small over time. But overall, this would bring hundreds of billions of dollars in savings that would allow for us to have lower taxes, more economic activity, and more patient control of their healthcare, while doctors get paid more as well. That's more along with their charges. And so I think that combining these things, Dr. Deane, is so important, because I think we're realizing that there's going to be some role for government. It's probably going to be too much for my liking, and maybe even for yours. There's going to be some role. But I think what we've been able to do is highlight, here are broader reforms that need to be made in the healthcare system, and here are specific reforms that we can make to Medicaid, for example, and even Medicare. We talked about these senior health savings accounts that can allow for us to get to the patient and doctor relationship. That's really what we want to empower patients, right?
Yes.
What would you add to some of that, though?
The block grant idea is not new, but has been, let's just say, met with less than enthusiasm. Certainly, the states, or should I say, bluntly, the the states that benefit from this FMAP situation, like California is a great example. They put everything they can think of. They just enrolled 700,000 illegal aliens, illegal residents into Medi-Cal, which is California Medicaid. Well, what does that do? That increases their budget by something like $2 billion just for that population, which means that the government has to give them $2 billion more dollars because that's the way the matching program works. So you just said, perverse incentive. That's exactly right. This is an incentive for the states to spend more money. Now, block grants, will, especially if they're unrestricted, will allow the states to design their medical safety nets, which is what we're talking. That's what Medicaid is. Will allow them to design the. I always get a laugh out of saying, well, the federal government has a one-size-fits-all. So you've got, and the two states I love comparing are Montana and Rhode Island. The reason I like comparing them is they have the same population, which is 1 million people. Okay. Same number of people. Okay. Except that Montana has 1,100 doctors spread out among 145,000 square miles. And Rhode Island has 5,500 doctors in 1,200 square miles. Wow. Now, to say that both states should have the same system of providing care is ludicrous. Okay. So who is best to decide how to structure their resources, the resources of hospitals and doctors and where the patients are and what kind of illnesses? There are certainly more farm tragedies and farm trauma in Montana than there is in Rhode Island, et cetera. In other words, both the needs and the resources are very different in those two states. And who better to decide how to do that? The state. Not the federal government, one size fits all. No. So block grants are unrestricted. Block grants are clearly the way to go, both medically and financially. Financially, both for the state and for the federal government, and most important for the patients. But there's political resistance. Yes. Yeah, we're seeing it all the time. I mean, even in Texas, they keep finding ways to increase the FMAP and everything else because they want to bring down money to spend. That's right. They want to garner more taxpayer dollars, and we want to reduce the burden on the taxpayer and give the taxpayer his or her money to spend on himself or herself rather than let the government tell you how they're going to spend your money. Yeah. Well, I think those are some of the really big parts of the book, right? There's a lot more to it that the audience will need to go out and read and hopefully read the report for those who are interested. I mean, I want everyone to read the report as well because there's a lot of good details. But if you're not a policy wonk, read the book first and then do that. But for the policy wonks, maybe do it the reverse opposite, whatever you want to do. But I think there's a lot of good information in both of these where basically we're trying to get government out of the way. We were fortunate to have Grover Norquist, who's president of Americans for Tax Reform. He did the foreword on this. He has a podcast called Leave Us Alone and a book he just released called Leave Us Alone. It's not just about healthcare, but in general, but it falls directly into what Dr. Deane and I are talking about here,
within healthcare is to leave us the hell alone. Allow patients to make the decisions and doctors to come together, and we can have a much better system. One day, Dr. Deane, it might be cool to have one of those videos to where you see a dark area where we have our healthcare system that's working. People are getting healthy in some capacity, but it's still kind of dark and doomsday and higher cost. Then it's one of those things where you open the door and you go into this more of a paradise of a healthcare system that allows for markets, which markets are just people. It allows for people to determine where those resources are going to go. And I believe strongly, Dr. Deane, with this approach, that we will let people prosper for one part of this, because we can lower taxes, we can allow for more economic activity, but we're going to let people prosper not only materially, but also through their health. People are going to be healthier because the incentives will be better aligned, and families can be together longer and happier. I mean, this is a much better situation than kind of the doomsday scenario that we see too often in our healthcare system. But as we're wrapping up here, and this has been an awesome discussion, to have you back on so we can talk about this some more. But what else have we missed? Or what else would you like to close us out on, so we can make sure that we leave the readers and the audience in the best situation moving forward?
For me, in a broad sense, it's very simple. The best person, the right person to decide your care is you.
Yeah.
And the way you can regain that authority is by controlling your healthcare spending rather than having somebody else, whether it's the government or an insurance executive, have them decide your spending and your care. And that's what we are aiming for.
Amen. Good stuff, Dr. Deane, as always. Thank you for being on the Let People Prosper show, and thank you for all the work you're doing and for being a wonderful author and mentor to me for so many years. And I'm hopeful that we can get people to understand and empower Patients Initiative, get the book, and hopefully get policies changed across the country. So thank you so much, Dr. Deane.
My pleasure. I'm glad to try and help people regain authority, power, control, whatever word you want to use.
Yeah.
We, the patients, should be in charge.
And one other thing to mention here is that the book proceeds are going to a charity, right?
That's true.
Which charity is it again?
My wife and I were big supporters and are big. Well, my wife is deceased. Big supporters of Canine Companions for Independence. We just think that that's a great partnership of helping our veterans with service dogs, basically.
Yeah.
Well-trained service dogs. And so, yes, the proceeds will go to them.
Yeah. Yeah. Awesome stuff, Dr. Deane. Always good talking with you. So thank you for being on. And for the audience, I'll put all this and more at my show at vanceginn.com and the show notes page at vanceginn.substack.com. And we're going to have a website for all this that I'll put in the show notes as well. But I really wanted to bring Dr. Deane on to talk about our report, Power Patient Initiatives, and the book, Empower Patients, 2 Doctors Cure for Healthcare. These are going to be available on Audible. We're going to have a Spanish version of this available and so much more that I'll make sure to put in there in the show notes as well. But I really think it's important for us to understand the healthcare system and understand it's not a free market and how we can move forward. And I think we really can empower patients and let people prosper at the end of the day. So until next time, God bless you and let people prosper.